In this study, 106 adult patients presented with classic upper extremity symptoms: neck pain radiating down the arm, numbness, and localized weakness, all textbook indicators of cervical radiculopathy. To locate the exact nerve lesions, physicians ran comprehensive electromyography and nerve conduction studies across 126 symptomatic limbs. Despite the severity of their symptoms, 60.3% of these limbs yielded absolutely no electrophysiologically detectable pathology. The remaining positive EMG findings split into three distinct streams. Only 15.9% proved to be isolated cervical radiculopathy. Another 18.3% had carpal tunnel syndrome, and 5.6% demonstrated double crush syndrome. That means nearly a quarter of the patients evaluated for neck issues actually suffered from distal nerve entrapments in the wrist or multi-site compressions. Clinical presentation alone lacks the resolution to differentiate true cervical root axonal damage from distal entrapments or non-radicular referred pain. Standard cervical MRIs present a distinct clinical challenge. They frequently reveal incidental bulging discs that have no correlation with the patient's actual pain. Simply identifying the presence of a herniation is inadequate. Physicians must map its precise mediolateral spatial geometry to determine if it is actively compressing a nerve. To do this, we have to zoom in from the macroscopic clinical presentation to an isolated axial slice of the cervical spine. This is where the foramen-facet spinal, or FFS, classification system comes in. It provides a rigorous anatomical framework to predict actual neurophysiological failure. By cross-referencing this strict MRI morphological map with objective EMG data, we can identify exactly which herniations will cause measurable peripheral neuropathy. This illustration details the core architecture of the FFS classification system on an axial view. The system uses a posterior extension severity scale. Grades 1 through 3 measure precisely how far the disc material protrudes backward toward the spinal canal. It also uses a mediolateral lettering system. Zones A, B, C, and AB map the specific horizontal location of the compression relative to the center line. Look closely at Zone A. This is a strictly sagittal or median herniation. The mass presses directly backward toward the spinal cord itself, bypassing the lateral nerve roots. When we map the study's data to this zone, a clear pattern emerges. 44.7% of patients with absolutely no pathology detected on their EMG were clustered right here in Zone A. This aligns with medical consensus. Central disc herniations are anatomically positioned to compress the spinal cord, driving myelopathic symptoms rather than inflicting direct damage on the peripheral nerve roots. Large central herniations may look severe on a standard MRI, but they frequently spare the peripheral nerve architecture entirely, creating a diagnostic mirage of radiculopathy. Let's shift focus to Zone B. This is the paramedian or lateral region, situated exactly where the neural foramen begins. Here, a protruding disc mechanically compresses the exiting cervical nerve root, creating a primary point of physical injury. Because this specific paramedian spatial geometry directly intersects the path of the nerve root, it correlates significantly with definitive electrodiagnostic evidence of cervical radiculopathy. This chart shows the distribution of cervical root level involvement across the 27 symptomatic arms with confirmed cervical radiculopathy in the study. The C6 root at 41% and the C5 root at 32% are the overwhelming targets of these focal paramedian insults. Zone B represents a straightforward diagnostic scenario. Direct structural impingement on the nerve root results in measurable, localized axonal degradation. The structural clarity of Zone B disappears when we look at the most complex and diagnostically treacherous region of the MRI, Zone AB. Zone AB defines a massive combined herniation spanning both the sagittal and paramedian regions simultaneously. This wide anatomical footprint generates chaotic diagnostic data. Zone AB contains exactly half of all confirmed cervical radiculopathy cases, but it also contains the vast majority of isolated carpal tunnel and double crush cases. To explain this heavy clustering of seemingly unrelated nerve pathologies, we have to look at double crush syndrome, a concept first proposed by Upton and McComas in 1973. Double crush syndrome describes a microscopic interruption of axonal transport mechanisms flowing down a nerve fiber. A proximal blockage in the neck creates downstream weakness. Proximal compression at the cervical root reduces the peripheral nerve's biological tolerance to entrapment further down the arm. This physiological vulnerability directly predisposes patients to secondary distal entrapments, specifically at the median nerve in the carpal tunnel. This presents a hidden danger. If a physician only looks at an MRI showing a severe AB zone herniation, an isolated case of carpal tunnel syndrome can be easily misdiagnosed as primary neck pathology. Zone AB is a multi-site risk factor. Its wide structural footprint creates an anatomical cascade where proximal nerve irritation actively masks or amplifies distal nerve failure. The straightforward neurophysiology of a focal zone B herniation stands in sharp contrast to the compounded failures seen in zone AB. Treating a zone AB patient with cervical surgery based solely on their neck MRI leaves the downstream pathology untouched. Operating on the cervical spine without identifying a coexisting carpal tunnel entrapment guarantees that the patient's symptoms will persist unresolved. As for the 60.3% of patients with normal EMGs, a negative electrophysiological study does not mean they are faking their symptoms. Central herniations, microvascular compromise, and inflammatory mediators can all cause severe, radicular-like pain without actively destroying the motor unit potentials that an EMG measures. Precision diagnostics require reconciling the exact spatial geometry of the spinal lesion with the functional capability of the entire nerve pathway. The primary clinical rule derived from this data is clear. Whenever an MRI indicates an AB zone herniation, standard assumptions must be discarded. A combined EMG and nerve conduction evaluation is strictly mandatory for zone AB patients to accurately rule out carpal tunnel and double crush syndromes before any surgical intervention. Clinicians must also look beyond the typical C6 and C7 nerve roots, noting the unexpectedly high prevalence of C5 root involvement in this patient cohort. Further research is necessary to elucidate the exact pathophysiologic mechanisms driving severe pain in central zone A herniations, where axonal damage is entirely absent. Resolving the diagnostic delta in upper extremity pain requires treating the peripheral nervous system as a single, continuous, and highly vulnerable circuit.